Thank you, sir, and good afternoon, all. The abstracts which I'm going to present are pertaining to a topic which actually is not associated with the clinical management of breast cancer, but what we face in our clinical practice after we treat the patients. So that is about pregnancy after breast cancer. We have been seeing a lot of young patients nowadays in our clinics who get diagnosed with breast cancer, and as we know that they are interested in future fertility. So fertility preservation and subsequent childbearing is of paramount importance for all these patients. And these fertility concerns, they not only affect the quality of life, but they may even negatively affect the treatment decisions, because some of these patients may even forego the recommended treatment owing to the risk which they feel for infertility. Also, there are various unique challenges, especially in patients with hormone-positive breast cancers, like they are at more risk, what we think of, especially if they have a pregnancy. That was a thought process. And another important subgroup, that is BRCA positive. So the next two abstracts try to shed some light regarding both these issues. So the first abstract is regarding pregnancy after breast cancer in young BRCA carriers. It was an international hospital-based cohort study, a very recent publication from JAMA in January 2024, and authored by Dr. Lambertini and colleagues. So we know that the previous studies, it has demonstrated that it is feasible and safe for pregnancy in breast cancers, but there is a limited data for BRCA carriers. So the question was whether these patients who are BRCA carriers and breast cancer patients, is it safe to undergo pregnancy, or whether it is associated with any maternal or fetal outcomes. So to answer this question, the study was undertaken to investigate the cumulative incidence of pregnancy and disease-free survival in young women who were BRCA carriers. So it was an international multi-center hospital-based retrospective cohort study conducted at 78 centers. Female patients with IDC and age 40 years of younger between January 2000 and December 2020, so almost around 20 years, and those who were having a BRCA mutation were included. The primary endpoint was cumulative incidence of pregnancy after breast cancer and DFS, and the secondary endpoint was breast cancer-specific survival, overall survival, pregnancy, and fetal obstetric outcomes. Around 5,400 odd patients were assessed for eligibility, out of which 4,900 patients were eligible, and 4,732 patients who were BRCA carriers were included. And out of that, around 659 patients had at least one pregnancy after breast cancer. The remaining 4,000 odd patients did not. The median age at diagnosis was around 35 years, and the cumulative incidence of pregnancy at 10 years was 22%. So roughly around 1 out of 5 patients could achieve a pregnancy, and the median time from breast cancer diagnosis to conception was 3.5 years. Among the 659 pregnancies, roughly around 7% had induced abortion, and around 10% had a miscarriage. Overall, it was seen that those patients who could achieve pregnancy were more likely to have a younger age at diagnosis, and also they were more likely to carry a BRCA1 mutation. They were more likely to have a node negative and a hormone receptor negative disease, and more likely to would have undergone a breast cancer conserving surgery. Coming to the results, out of the 517 patients who had a completed pregnancy, 91% patients had a full-term delivery, and 54, that is 10% patients had twins. And among the 470 infants who were born with a known information, only a 0.9% had a documented congenital anomalies. So it was not too high. And the median follow-up was around 7.8 years. So these are the cumulative incidences of pregnancy overall, and according to the hormone receptor status. As we can see on the right side, the patients who were hormone receptor negative were more likely to have a higher cumulative incidence of pregnancy as compared to those with hormone receptor positive, maybe because they would receive an adjuvant endocrine therapy. On the left side, we could see the secondary endpoints of pregnancy, fetal, and obstetrical outcomes. Some important points to highlight is that almost 80% of these patients, they could achieve a spontaneous pregnancy, and only 20% required some assisted reproductive techniques. So that is even after majority of these patients receive chemotherapy. So they could still fairly have a good ovarian reserve. But having said that, all these patients should be encouraged to do a oocyte or cryopreservation. Another thing is that almost 87% of the patients didn't have any major complications. So that's also an important point. So overall, it was seen that there was no significant difference in the DFS, which was observed between the patients with or without pregnancy. On the contrary, it was seen that those who could achieve a pregnancy had a slightly better or significantly better breast cancer specific and overall survival, with adjusted hazard ratio of 0.58 and a p-value of 0.005. So this was something important. If we see the subgroup analysis, there is an important point to note that there was a significant interaction between occurrence of pregnancy and a specific BRCA gene. So here if we see the univariate hazard ratio for a BRCA2 gene was 1.6, and multivariate hazard ratio of 1.55 as compared to BRCA1. So it was seen that pregnancy appeared to be associated with the lower event rates among BRCA1 carriers. And on the contrary, the BRCA2 carriers, there was a slight signal for a possible association of pregnancy with adverse disease-free survival. So this is a point which we have to take into consideration. Overall, to conclude, we can see that 1 in 5 young BRCA carriers could achieve conception within 10 years, and it was not associated with any adverse maternal or fetal outcomes or decreased DFS. So quickly going to the second abstract, because it's in the same context, it's about interrupting the endocrine therapy to attempt pregnancy after breast cancer. This was from the positive trial group, published in NEGM in May 2023, and authored by Dr. Patridge and colleagues. So we know that there is a lack of prospective data regarding interruption of adjuvant endocrine therapy for attempting the pregnancy, and that's the reason why the study was undertaken to evaluate the temporary interruption of adjuvant endocrine therapy to attempt pregnancy in young women with previous hormone-positive breast cancer. So positive trial was a international multi-center investigator-initiated single-group trial, which was that was collaboratively designed and conducted by the International Breast Cancer Study Group. The patients were enrolled from 116 centers, and the eligible women were 42 years of age or younger, had stage 1, stage 2, and stage 3 disease, and they should have received at least minimum of 18 to 30 months of endocrine therapy. So this is the trial protocol. The patients had to stop the endocrine therapy within 1 month of enrollment, and there was a 3-month of washout period, and the duration of interruption of this endocrine therapy was up to 2 years, which was allowed for attempting the pregnancy, conception, delivery, and breastfeeding. Use of assisted reproductive techniques were allowed, and as soon as the desired pregnancy is completed, it was strongly recommended that they complete the planned 5 to 10 years of treatment. The primary endpoint was the breast cancer event. Now, breast cancer event was defined as any local, regional, or distant recurrence of invasive breast cancer or a new contralateral breast cancer during follow-up. And the primary analysis was planned to be performed after 1,600 patients' years of follow-up. And there was a predefined safety threshold, and that was the occurrence of 46 breast cancer events. Now, this treatment outcomes of this group were compared to an external cohort, and that was consisted of a woman who would have met this criteria, and this external cohort was taken from the soft and the text trials. So from December 2014 to December 2019, that is up from 5 years, around 518 patients were enrolled, and 516 patients were evaluated for a primary efficacy analysis. The median age was 37 years. The median time to enrollment was 29 months. And point to note here is that almost 94% patients had a very early disease, stage 1 and stage 2. So only 5% to 6% had a stage 3 disease. Among 97 women who were followed for the pregnancy status, 74% had at least one pregnancy, and total 365 babies were born in this period. After a median follow-up of 41 months, 44 patients had a breast cancer event. The point which was set was 46 safety threshold. So it was close, but it did not cross. So overall, the cumulative incidence of breast cancer events was not different. It was 8.9% in treatment interruption group, and it was 9.2 in the cohort. And the distant recurrence rates were also not different. Overall, it was seen that younger age was only factor which was related to the successful pregnancy, and almost 40% had to use assisted techniques, and the complication rate was not that high. In secondary endpoints, we can see that almost 86% patients had a live birth, and almost 80% had a full-term delivery. So overall, to conclude, though we know that 5 to 10 years of treatment is recommended, but those who are desperate or those who really want to try for a pregnancy, a temporary interruption can be attempted without a very negative short-term effect, but still we need to have a longer-term data. So my take-home message from both these trials, because those are closely related, both these studies now we have some data to guide for patients for informed decision-making, because these questions come up in our clinic. So we now have some data to back up our answers, but again, patient selection is the key. So I would think of giving these options to my patients who are really early stage TNBCs or maybe BRCA1, as we saw that there is some discrepancy in the BRCA1, BRCA2, and young and early stage hormone positive after initial endocrine therapy. But whatever said and done, we need to still have a longer follow-up data for confirmation of these results. Thank you.